Hello, everyone.
Hello,
Wishing
hello.
you all a very good morning, afternoon, or evening, depending on which part of the world you're joining from. This is your host for today's webinar, Dr. Saba Amjad. I'm CEO at Heartfile, and I welcome you to today's event. In the best interest of time, I am not going to go over the usual housekeeping notes for webinars, assuming that thanks to the pandemic, we are all familiar with the virtual meeting platforms by now. The purpose of today's webinar is to disseminate the findings of country case studies on the upstream financing of non-communicable diseases conducted by Heartfile in 10 low and middle income countries. We will be joined by several internationally well-respected panelists from around the globe and organizations. Sir George Allen, the Regional Director Emeritus PAHU, will grace the webinar with his keynote, while Dr. Sania Nishtar, Advisor to Prime Minister of Pakistan on Social Protection and Poverty Alleviation, has gracefully agreed to moderate the session for us. The recording of the webinar and copy of the presentations will be available on request by writing to us at info@heartfile.org. I would also like to share that the 10 case studies series will be published in a compendium in a special supplement of JPMA, and we will share and disseminate the link once it is available. Without further ado, I'll now hand over the floor to Dr. Sania Nishta for taking it further. Thank you.
Thank you, Sabah. Good day, colleagues and friends. I really want to join Sabah in welcoming you to this webinar. And thank you, Sabah, for asking me to moderate. I've had the privilege of founding Heartfile, but over the last 2.5 years, I have been totally dissociated with the organization, having accepted to serve in the government. And I want to congratulate Sabah and her colleagues for the wonderful job that they're doing. Specifically, today's webinar is about the dissemination of a country case series that I was involved in conceptualizing, but I really want to congratulate Amar in taking it forward and for the wonderful work that he's done in bringing it to fruition. The importance of NCDs has only been reiterated during this pandemic, and I think this is what I would like to say as a starting point. But today we really look forward to hearing from Amar, and then remain ever so thankful to Sir George for accepting to keynote today. And I really want to thank Douglas Betcher, who was a former director at the World Health Organization. He's globally renowned, does not need an introduction. My friend Johanna Ralston, who's now the CEO of World Obesity, equally does not need an introduction. Both of them have stellar contributions in non-communicable diseases. Both are close friends whom I've had the privilege of working with over the course of the years. Dr. Palitha, our very dynamic WHO representative in Pakistan, great champion of NCDs, is somebody I know very well, has also kindly consented to serve as a panelist today. Thank you so much for all that you do in Pakistan and for the support that you lend to NCDs. And I want to thank especially Madiha from IDRC, a very enterprising young Pakistani who's making her mark in Canada in IDRC, who's a great supporter of non-communicable diseases. And I also want to thank her for supporting this work. So with this, I would like to now hand over to Amar, the author of the report, for his presentation. Over to you, Amar.
Thank you so much, Dr. Sania, and good afternoon, good evening, good morning, depending on your time frame, to all the panelists and attendees today. I think I won't waste any time. I'm just going to share my screen and just, okay, I just need the host to enable screen sharing, please. It's not allowing me. saying it's currently disabled.
Amar, they're just sorting it out.
Okay.
Just bear with us.
All right, sure. आपने डिसेबल किया बस. Okay, while we wait, I guess I can just I can like start talking about some of the background of the study, and we can join in whenever sorted out the technical issues. So basically, today's presentation is around, as we all know, around the 10 country case studies on NCD prevention financing in low and middle income countries. I think okay, they've. Can everyone see the screen now?
Yes, Amar, we can see your
All right.
screen now. Thanks. If you could bring it to full screen, please. That's perfect. Thanks.
Right, okay, we can begin now. So today's presentation is basically around the findings of the 10 country case studies on NCD prevention financing in low and middle income countries. The focus of the study was basically on the investigating the enablers of and challenges to NCD prevention policies and their financing in these countries. The idea was to identify both challenges, what kind of determinants these policies have, and to and opportunities and areas for further study. And basically, the idea was to focus on population level interventions rather than either curative or treatment related spending, or even on individual screening that is also a form of prevention, but nonetheless, it's not at the level of the population. In the research design, it was decided to focus on 4 major risk factors, including tobacco use, harmful use of alcohol, unhealthy diets, and physical inactivity. Though we also, after the first initial review, decided to incorporate environmental variables as well, which have been included in the papers. And the 10 countries that have been studied are Jamaica, Mongolia, Vietnam, Pakistan, Sri Lanka, Tonga, Kenya, Belarus, Zambia, and Iran. So just briefly on the methodology employed, it was, we basically employed a critical theory approach based on the nature of the research, which was around a wide diversity of contexts with varying socioeconomic backgrounds and geographies and regions. So we decided to adopt this approach to look at a reality as contextualized, to look at the various social, political, cultural, and economic variables that shape policies and government budgets, and to basically collect different kinds of narratives that are specific to each social context, and as a means and look at this research as a means to bring about transformation rather than simply undertake some kind of dispassionate analysis that is disconnected from the actual social reality it is studying. So we basically employed a mixed methods methodology that looked at first reviewed academic and gray literature around NCD prevention and control in each country context. We analyzed budgetary and financial data, policy documents, and various evaluations of programs and projects done related to NCD prevention and control. Then after that, after collecting this baseline of evidence, then we conducted interviews with key country informants who work on NCDs and their prevention within the public health sector in each country. And from those respondents, we also snowball to other sources of information and data to further refine our analysis and come up with categories for the analysis. The criteria for the inclusion in the study was basically based around 2 steps. It had to be a WHO member state as a high burden country as defined by WHO, and countries where either investment cases were completed or the country missions had taken place with respect to NCDs. Other criteria included a geographic balance, countries where costs of prevention could be determined, and where diversities of approaches could be studied, and determinants of failure could also be explored. In terms of definitions, I think there's two key definitions that I play here for the analysis. One is that for public financing. We decided to look at it in terms of resources that were mobilized at the country level as well as at subnational levels. And this includes a development assistance or donor assistance from external sources, provided that it was routed through the government rather than going through other civil society sources. So essentially, it is looking at public spending and development assistance that is also routed through the government. Prevention was defined as those preventative and public health services which are designed to enhance the health status of the population as a whole, as distinct from curative services which try to repair health dysfunction. So in terms of the context of this of the research, I think it's absolutely one of the most critical issues facing our planet today. 71% of global deaths are caused by NCDs around the world, which or around over from 2020 to 2030, these are estimated to cost around $47 trillion in global GDP losses. And 85% of premature deaths from NCDs per year take place in low and middle income countries. And the economic losses to lower middle income countries from just the four main NCDs are estimated to surpass $7 trillion in the 15 years between 2011 and 2025, an average of $500 billion a year. These NCDs are generally, I mean, I'm sure as a panel and our attendees are aware, they're associated with urbanization, lifestyle changes, dietary changes, and demographic and epidemiological transitions that are taking place around the world as societies develop. Despite the fact that now these diseases account for the bulk of health spending as well as and contribute inordinate cost to GDP, health spending in most or many LMICs remains focused on infectious diseases and curative or treatment expenditure. And other studies have shown us that limited availability of funds for NCD control and prevention are an important reason for their continued persistence. And finally, I think in the context, this wasn't the context, obviously, when we started out doing this, but now obviously everything has been overtaken by this and is by the COVID-19 pandemic. And this is obviously intimately connected to the NCD crisis. The comorbidities that greatly enhance the death toll from COVID infection are largely related to non-communicable diseases. And it is essentially the underlying health crisis which has made the COVID-19 pandemic so deadly in populations across the world. So just briefly to look at, to start off, we looked at the disease burdens by country. And in all of the LMICs studied, with the exception of two countries from Africa, Kenya and Zimbabwe, NCDs are the dominant cause of mortality in all the LMICs studied. In particular, cardiovascular disease, which ranges from 8% in Kenya, 8% of mortality in Kenya to up to 62% in countries like Belarus. And this is followed by diabetes and cancers, and then other NCDs in terms of their contribution to mortality. In terms of risk factors, again, there's a wide variation across countries. You have places like Belarus, where tobacco and alcohol are massively, are some of the main risk factors compared to other countries like Pakistan, where often it's more about diabetes and physical inactivity. Unhealthy diets are basically a major risk factor in every single country studied, and much more so than others in places like Jamaica and Mongolia. Unhealthy dietary patterns, particularly low fruit and vegetable consumption, are pretty much the characterized. The majority of the population is characterized by these. In terms of healthcare financing, again, so there's a wide range, there's a wide diversity across the countries studied, where you have countries, highly populated countries like Pakistan, where per capita health spending is as low as $37 per capita, to countries like Iran and Belarus, where it is as high as $555 to $373 per capita. You also have, we also have a great deal of diversity in terms of the distribution of overall health spending. You have countries like Belarus and Jamaica, where the government health spending accounts for the vast bulk of overall health expenditure, over 60 to up to 70 almost percent in some cases. And you have countries like Pakistan, where it accounts for as low as 27%, or in the case of Zambia, as low as 34% of overall health expenditure. So again, it's a wide variety of contexts, but nonetheless, one common thread is that with the exception of Zambia, and to some extent Tonga, most of these countries are largely mobilizing revenues for health from indigenous sources. And it's only Zambia where the bulk of healthcare expenditure is still carried out through development assistance. Now moving towards spending on NCD prevention, which was really the focus of this analysis. We were able to do this for at least 9 out of the 10 countries studied. And what we essentially found is that NCD prevention accounts for a minute fraction of health spending and public health spending per capita. It ranges from spending as low as $0.03 per capita, or less than $0.3 per capita in the case of Pakistan, to as high as $13.4 in the case of Tonga, which of course should be qualified by the fact that it's a country with a population of just over 100,000 people. And so it's probably not fair to make comparisons with much larger countries like Pakistan, Vietnam, etc., tens of millions of people. But nonetheless, the common thread that we see is that across the board, across LMICs, countries are spending a tiny fraction of overall health spending on NCD prevention. And as a proportion of public health spending, it ranges from as low as 0.02% in the case of Belarus to up to 5.9%, 5.98% in the case of Tonga. There are some countries for which this estimation is these figures are only an estimate, principally such as in the case of Vietnam, Pakistan, and Zambia, principally because these countries are not yet distinguishing their NCD spending, are not separating prevention expenditure from curative expenditure on NCDs, which again, I think is a symptom of how low the prioritization of NCD prevention in these countries is, that it's not even being budgeted for separately. Again, so just to look at the graphic comparison of these contexts, you can see in most countries, the per capita NCD prevention spending is extremely low. Again, Tonga is an outlier principally because of the low population. It's about 120,000 people. Otherwise, almost all countries, the NCD prevention spending per capita is less than $3 per capita in each country. So as was just spoken of, there is a mismatch in terms of the disease burden and spending priorities across country contexts. In most contexts, you have the share of NCDs and overall mortality is often higher than 70 or 80%, up to 91% in countries like Belarus. Yet there is no country, with the exception of Tonga, where NCD prevention spending is greater than 3% of public health spending. So there's this enormous mismatch in what the disease burden is, and what healthcare costs are, and in what is being spent on preventing these diseases. So there is other like beyond the study, there have already been investment case studies carried out in 4 of these country contexts that were studied. And the evidence in that is clear that investment in NCD risk reductions are cost effective, and they bring about sustained returns on investment, both in terms of lives saved, which can go into the thousands or even the hundreds of thousands in the case of Belarus, and in terms of inordinate productivity benefits, which can range from $4 million over the next 15 years in the case of Zambia to $5.6 billion in the case of Belarus. And you can see that in all country contexts where investment cases have been carried out, it's clear that the return on investment is much higher than the actual cost of those investments. So this ranges from $2.1 for every dollar invested in the case of Jamaica to up to $94 return on risk reduction interventions in the case of Belarus. So I'm just going to briefly go over some of the country snapshots. Obviously, these are detailed papers that have been done on each of these countries. We can't go over each of them in greater detail given the time constraints, but just I'll go over briefly some of the key sorts of lessons that emerged from each of these country case studies before moving towards the overall synthesis. So Jamaica is one of the countries that is a relatively better performer in terms of its policy focus and spending priorities in terms of NCD prevention. It has an 80% share of NCDs in overall cause mortality. It has a relatively high level of health spending per capita and a high level of share of public health spending out of total health expenditure. And among the country studied, it is also amongst the higher spenders on NCD prevention. Some of the enablers of Jamaica's progress have been um, the fact that it has been one of the few countries where taxes on alcohol, tobacco, and gambling have been earmarked for NCD prevention and health promotion through the National Health Foundation and the Chase Fund. Jamaica. Jamaica has been very well served by its own chronic disease prevention unit in the Ministry of Health. It's one of the countries that has carried out national health campaigns such as Jamaica Moves, which have encouraged health promotion and healthy physical activity amongst the population at large. And it has been very well served also by regional collaboration for NCD prevention by under the Caribbean countries framework and PAHO, and also civil society advocacy for NCD prevention and risk reduction. Some of the challenges in Jamaica have related to alcohol and tobacco industry, lobbying against taxes, and the government's apprehensions about employment, about unemployment, and falls in investment that could result from tobacco and alcohol taxation, and which actually did come about in one of the instances whereby after one of the main tobacco manufacturers in Jamaica moved out of the country, following an increase in excise taxes some years ago. There has been one of the challenges again is there has been a slowdown in allocations for NCD prevention in recent years, which has not really kept pace with inflation. And government officials that we spoke to talked about the fact that tax increases are somewhat politically untenable. The current government pledged to not increase indirect taxes, which has led to tobacco and alcohol taxes sort of falling behind inflation and not being as effective as they were some years ago. And like in many other countries, nutrition interventions and dietary risk factors have not been prioritized as much as alcohol and tobacco and physical activity risk reduction. Mongolia is another country which is something of a middle performer. It's another country that has high levels of government health spending in terms of overall health expenditure, in terms of the share of overall health expenditure. And it's also made a lot of progress in terms of improving life expectancy. Yet NCD prevention continues to be very low per capita, and it's about 1% of overall health expenditures. The enablers of NCD prevention spending and policies in Mongolia have been its immense progress that is made on tobacco tax and regulation, for which there has been a lot of political will demonstrated by the government. Mongolia has also, like Jamaica, established a health promotion foundation for which taxes from excise taxes from tobacco and alcohol have been earmarked. The foundation was sort of it was discontinued in between for some years because of a lack of sort of political stewardship, but a couple of years ago it was reinstated, and it is again the fulcrum of NCD prevention efforts in Mongolia. And then Jamaica has also been one of the leaders in sort of developing this this healthy settings approach, whereby cities, workplaces, schools are made the fulcrum of NCD prevention efforts, and local governments, civil society organizations are involved in encouraging health promotion and physical activity and other healthy activities among the population. Some of the challenges, like in other countries, is the influence again of domestic alcohol industry, which is very economically important manufacturing sector in Mongolia, and also the food and beverage industry, which has sort of resisted efforts to reformulate its food products to reduce dietary risk factors. Surveillance and information gaps continue to be a major challenge in Mongolia, which has not yet been able to establish a comprehensive e-health system that also incorporates NCD prevention indicators. And again, diet interventions are still limited, and this is a very underserved area because obesity in Mongolia is rising rapidly, and salt intake continues to be amongst the highest per capita in the world. Sri Lanka is another country that has made relative progress in terms of developing NCD programs and policies, and also increasing spending over time. Nonetheless, it is still spending as low as $0.23 per capita on NCD prevention, and it just spends 1% of its overall government health spending on NCD prevention. Nonetheless, Sri Lanka has had successes in certain areas, particularly through its anchoring its prevention services in its healthy lifestyle centers, which are basically primary healthcare units, which have carried out not just screening for NCD risk factors and conditions, but also outreach efforts to help increase population awareness about the risk reduction. Sri Lanka has also been very proactive in establishing permanent institutions within the Ministry of Health, such as the NCD Prevention Unit, Health Promotion Bureau, the National Alcohol and Tobacco Authority, which has spearheaded alcohol and tobacco taxes in Sri Lanka. It has also employed the healthy settings approach to encourage health promotion in schools, villages, and workplaces through a community-based approach. And carried out things like competitions and rankings-based systems that sort of incentivize health promotion and physical activities in these areas. It has also been a case where political leadership has, in multiple instances, resisted pressure from industry when it comes to tobacco and at times alcohol, and continue to increase taxes at times. And there has also been a lot of civil society leadership for tax increases and health promotion for NCD prevention. Some of the challenges, again, relate to the influence of industry on related to tobacco, alcohol, and sugar policy and taxes. There hasn't really been a countrywide concerted health promotion and physical activity promotion campaign. It's mostly taken place at local levels, but there still needs to be a broader countrywide risk communication campaign. And salt and alcohol consumption continues to be very high in Sri Lanka, which is driving much of its NCD burden. Vietnam is a country which I think presents a very particular case. It's a country with a very well-developed health system. They made a lot of progress in terms of developing public health care and developing diversified sources of revenue mobilization for health. And obviously, it's made great strides in improving life expectancy and tackling infectious diseases. Yet at the same time, its programmatic focus on NCD prevention still continues to be relatively limited, and it just spends about 2 cents, $0.2 per capita on NCD prevention, and a very low proportion of its overall health spending. Though, of course, this should be qualified by the fact that Vietnam also has a very large per capita health spending compared to other similarly placed LMICs, which would obviously make the proportion of NCD spending lower. Some of the enablers of Vietnam's NCD policies thus far have been the fact that it's also attempted to earmark taxes. However, more around not as an overall health promotion effort, but specifically related to tobacco control. And it's earmarked excise taxes on tobacco for a tobacco control fund. And similarly, it's a country with there's a great deal of political commitment to health and overall social development, which does create an overall facilitative environment for health promotion, but this has not really been capitalized upon as much as it should have thus far. Some of the challenges in Vietnam include the fact that much of the NCD programs in Vietnam are still disease specific. They're vertical programs which look separately at CVDs, at cancer, at the diabetes, etc. Rather than taking a holistic approach that sort of tackles interrelated risk factors. Prevention is still very underserved in primary care in Vietnam, and studies have found that very few prevention and screening activities very few primary health units are carrying out prevention and screening activities. Tobacco use is still high, amongst the highest in the world, and tobacco taxes in Vietnam are still amongst the lowest in the world, which is really driving high tobacco use. And similarly, alcohol consumption is also rising. There has not really been a nationwide communications campaign around risk factors and and health promotion. And there are lots of data gaps that in terms of both NCD risk factors and also looking at the impact of taxes and policies, which can better inform policymaker efforts. Tonga, again, it's on paper, is one of the best performing countries in terms of NCD prevention spending out of the countries we studied. But this, again, needs to be qualified by the fact that it's the lowest population. It's a complete outlier in terms of population, which really is what drives up its high per capita NCD prevention expenditure at $13.4, and also its high proportion of health spending spent on NCD prevention, which are around 6%. Nonetheless, I think Tonga is a regional leader in NCDs. It has increased tobacco, alcohol, and sugar-sweetened beverage taxes over time. It has also effectively employed healthy settings approach to health promotion, which has, again, I think it's basically led to decreases. These policies has led to decreases, particularly in tobacco and alcohol consumption. Tonga has also established a health promotion foundation, which anchors its NCD prevention efforts. Even though, unlike other health promotion foundations, it is not financed by earmarked funds from taxation, but it is financed through budgetary allocations and through donor assistance, largely from the Australian Development Agency, AUSAID, uh, uh, which is AUSAID essentially provides a large part, around close to 50% of the money spent on NCD prevention in Tonga. And in recent years, Tonga has also started taking tax measures to incentivize healthy diets and improve the affordability of healthy foods in their countries. The challenges in Tonga, the principal challenge with respect to NCDs is obesity. It has amongst the highest obesity rates in the world, and they are also still rising. And they relate to unhealthy food consumption and the rise of processed food consumption and low levels of physical activity. And this is really, in our interviews with health officials there, this is really the priority for Tonga in the coming years. And this is what they're trying to work on, including through some innovative approaches as investing in infrastructure for physical activity, such as sidewalks, which was found to be a gap when they reviewed the NCD policies in the last 5 years. And then the affordability of healthy diets is also a key concern, and as is inefficiencies in fiscal administrative systems, which has not really led to effective utilization of the funds allocated for NCD preventions. Kenya is another is a country which is somewhat of an outlier in terms of the share of NCDs in overall cause mortality, which is low, relatively low at 27%. Nonetheless, despite the fact that Kenya's communicable disease burden is still its major sort of it's a major contributor to mortality in Kenya. Nonetheless, they have still, relative to the region, increased spending on NCD prevention in recent years, and it still forms a relatively high proportion of health spending compared to the other country studies at nearly 2%. Some of the enablers of Kenya's progress in NCD prevention have been regional collaboration for NCDs, which has helped drive some of its domestic efforts. Kenya has also creditably moved from disease-specific programs to integrated NCD programs, which looks collectively at all of these diseases and their interrelated risk factors. Kenya has established intersectoral committees for coordination on NCDs, which have also driven some of its budgetary increases in recent years. It has had a lot of success in recent years at reducing alcohol and tobacco consumption, which are amongst the lowest now in the region compared to other African countries. Some of the challenges include obviously the fact that much of the bulk of resource allocation for health in Kenya continues to be on infectious disease. Kenya has also experienced a process of fiscal and administrative devolution in recent years, to where powers have been transferred to counties, and that has led to that for a time led to certain kinds of gaps in its NCD response, because those counties did not really have the fiscal and administrative capacities to address some of the regulatory issues around alcohol and tobacco. and other instances, which led to some of those programs faltering for a bit. But now they are sort of helping to buttress county level capacity for dealing with NCD prevention. Again, one of the things that came out of the Kenya study was uh, the fact that NCD interventions have delayed results often results in them not being prioritized by policymakers relative to other more tangible health interventions. And Kenya has also has done research through the NCD Poverty Commission on non-behavioral risk factors, and it was found that in Kenya, distinct from many other LMICs, 67% of the disability-adjusted life years lost to NCDs are not from the four main NCDs, but from other conditions like the human papilloma virus and other chronic infections that are more related to poverty, which calls for a need to focus a lot on the poverty-related risk factors underlying NCDs in contexts and poorer LMIC contexts like Kenya. And one of the last challenges relates to rising obesity, and again, the fact that nutrition policies are still not geared towards tackling NCD risk factors. Zambia, another country where share of NCDs and mortality is still relatively low. It is a country where infectious disease still accounts for the vast majority of mortality, and it has extremely low levels of NCD prevention spending per capita, perhaps the lowest out of all countries studied. Um, and they have Zambia has basically just started developing a policy framework for NCDs. They've just developed a national NCD plan, and they recently, last year, launched the National Healthy Eating Campaign, one of their first major initiatives. Um, Obviously, challenges in Zambia include this historically high infectious disease burden, particularly the massive HIV/AIDS pandemic, which the country has been dealing with for several decades, which is now thankfully moving towards reduction. There's a lack of NCD prevention in primary care, a lack of availability of nutrient-dense foods, a lot of donor dependence in health. So a lot of health allocations continue to be driven by donor preferences. There's still really no institutions for coordination of NCD efforts. There are low levels of utilization of health budgets, and tax increases are very unpopular, partly because of inflation concerns and partly because of the role played by industry lobbying, particularly the alcohol industry. Um, Belarus is a very distinct case. It's an Eastern European country, formerly of the Soviet Union, where it has amongst the highest health spending per capita out of most LMICs in the world. And government health spending accounts for nearly 70% of all health spending. So it has a very well-developed, robust public health system. Yet at the same time, NCD prevention spending remains very low, and it's not really has not really been historically a policy priority. So some of the enablers in Belarus for NCD prevention include historically high levels of political commitment to public health, and recent progress in taxing alcohol and tobacco, which had reached dangerous levels following the collapse of the Soviet Union in the 1990s. And Belarus has also followed healthy settings approach, including a healthy cities initiative, which is sought to improve health promotion efforts in its cities. Yet at the same time, it faces a lot of very distinct challenges, which are very somewhat unique to Belarus. A lot of them relate to it's sort of the inheritance of the uh, health institutions from the Semashko Soviet era system, which was really focused a lot on health services and this practices of institutionalized specialist care, which all citizens of Belarus have to sort of go through annually. Which has really led to the underdevelopment of a primary care system, which can sort of track NCDs from the primary to the tertiary level. There's not really a continuum of healthcare as in many other countries. Nutrition interventions are still under prioritized, and they have not really been invested in Belarus. Belarus's alcohol and tobacco consumption, even though there's been progress in recent years at reducing consumption, they remain amongst the highest in the world, and low enforcement of regulations continues to be a problem. Health communication patterns also tend to follow very preset bureaucratic patterns established again from prior eras, rather than sort of tackling it based on local evidence that looks at disease patterns as they exist now. And there is a sort of inertia in terms of health reform. There is a fear amongst policymakers of reorienting the health system towards primary care, towards health promotion, rather than the existing constellation of services, which are heavily geared towards service delivery and curative treatment, which has really led to a large level of underutilization of resources, and resources being concentrated in these curative and treatment related services, and rather than as preventing diseases from occurring. And finally, Iran, last two studies, where it's a relative success story in terms of developing its NCD programs and high levels of health spending per capita and high levels of government health spending. Some of the estimates for Iran are still under process, and we'll be receiving some of those estimates on prevention spending in the coming weeks. But nonetheless, Iran has developed intersectoral NCD committees and a national action plan. It has involved universities in the development of a national NCD framework. It has developed separate NCD departments, institutions in the Ministry of Health, which have really led these efforts. It has carried out health promotion efforts such as the lifestyle promotion projects around the country for lifestyle changes related to NCD risk reduction. And some of the challenges in Iran relate to continued cultural preferences for certain kinds of dietary patterns, which remain very rigid, and the overarching sort of impact of sanctions and the difficulties they create, particularly for increasing taxes on unhealthy food consumption and on tobacco, which policymakers are reluctant to do given existing inflationary pressures. Finally, Pakistan is possibly the lowest performer in terms of NCD prevention out of all of the countries studied, even though it's has the bulk of its mortality now relates to NCDs. It has the lowest health spending per capita out of all the countries studied, lowest government health spending per capita out of all of the countries studied, and possibly the lowest NCD per capita spending out of all countries studied as well. Pakistan has had very intermittent progress on NCDs. A program was developed back in 2003, but it was sort of abandoned. There has been some progress in tobacco taxation, which has sort of helped control it, even if not reduce it significantly. But recently, provinces have developed provincial and national action plans, and there's a task force and working group for NCDs that has been formed, but many of these action plans or task forces still remain relatively unoperationalized. One of the better things that has happened in recent years is the development of food regulation authorities in the provinces, which have sort of started to establish a robust food regulation framework that has started now to look at NCDs as well. But at the same time, much of Pakistan's focus continues to be on infectious diseases, on mother and child health, and on nutritional deficits, which occupy the bulk of preventive spending. Diabetes is amongst the highest in the world in Pakistan. The tobacco and food industry continues to interfere in policy and prevent NCD prevention from really taking root in policy. There are massive data and surveillance gaps in most national surveys, and health information systems are not really recording NCD-related data. And there's a lack of also communication about the behavior and dietary risks, about which there is very low population awareness. And all of this is compounded by the fact that Pakistan's health system was decentralized in 2010, which led to many, many years of inertia in terms of developing decentralized plans around NCDs and risk reduction, which are only now starting to be sort of reoperationalized. So finally, I think moving towards the conclusion and the synthesis of our findings, just to look at the overall, what some of the enablers of NCD prevention spending across country contexts are, you can see that all countries studied have come up with national NCD strategies, though obviously they're in varying degrees of operationalization. The majority of countries, with the exception of Vietnam and Pakistan, have set up dedicated NCD prevention or health promotion units in their ministries or departments of health. Almost all, with the exception of Zambia and Mongolia and Vietnam, have set up multi-sectoral NCD committees that are steering NCD prevention efforts. And then after that, you can see like a wide variety of sort of a diversity of responses. Some countries have set up health promotion foundations that have sort of spearheaded health promotion efforts. 3 countries have earmarked taxes on unhealthy consumption for these funds. 4 countries have employed healthy settings approaches at local levels in workplaces and schools. And in a few countries, we have seen pioneering political leadership and also civil society leadership for NCD prevention, such as in Jamaica, Mongolia, and Kenya. Some of the challenges across contexts, you can see that the key challenge, I think, really shared almost across contexts is the interference of the tobacco, alcohol, and food industries in policy, which is really preventing a lot of countries from being able to develop policies that respond to the evidence and that actually address risks. And then tax opposition to tax increases is also one of the major reasons that alcohol, tobacco, unhealthy food consumption continues to be underserved in policies. For some countries, such as Pakistan, Kenya, Belarus, Zambia, health systems continue to be focused largely around tackling infectious diseases, even though their disease burdens have shifted. In many contexts, prevention continues to not be a focus, NCD prevention in particular, in primary healthcare services. And gaps in data surveillance are also shared across multiple contexts. And in many poor LMICs, underutilization of budgets continues to be a major problem, which is preventing countries from investing more in NCD prevention. So towards the conclusion, just to what are some of the key lessons we can draw from this research? I'm sure many of you have drawn inferences from what has already been shared. But just to summarize, so across all contexts that were studied, health programs, systems, resources remain predominantly committed to treating disease rather than preventing it. So what we really need, I think what the research tells us is we need to reorient our health systems from a focus on individual treatment at often much later stages, at much more costly treatment, to reducing the behavioral, dietary, environmental risk factors that are underpinning and causing those diseases. And this needs to be reflected not just in policy commitments, but in budgetary allocations for particularly NCD prevention, health promotion, and creating like a continuum of services from primary to tertiary care levels that tracks and sort of prevents NCDs. Secondly, infectious diseases and undernutrition continue to remain the focus of service delivery and preventative healthcare in poorer country contexts like Pakistan, Kenya, and Zambia. And what needs to be kept in mind is this is not an either or choice. It's not about you have to focus on either infectious disease or NCDs. The challenge in these contexts is really integration. It's about integrating NCDs in existing programs, in existing surveillance and information systems, in existing outreach efforts and communication systems, so that you can sort of utilize existing resources and disease response infrastructures to respond to NCDs as well. And there have been studies done in Kenya which found that if you integrate treatment for NCDs within existing screening and treatment mechanisms for HIV, you could avert more than 43,000 cardiovascular-related deaths over the next 5 years, in addition to obviously averting HIV deaths and infections. Thirdly, NCD-focused nutrition policies are underdeveloped in almost all of the countries studied. And this is a massive problem because processed food consumption is driving the rise in NCDs across these contexts. But the food and health policies of these countries have yet to catch up. And policies to reduce consumption of salt, sugar, trans fat, and other unhealthy foods are still in infancy in most of these contexts. And what we really need are food systems approaches, which is not just like small regulatory changes or just tax increases, but an approach that looks at the entire food system in each country context, looks at what food is being produced, how it looks at incentivizing healthy food production, and then also incentivizing consumption patterns to make sure that people are also sourcing those foods and buying them rather than continuing to consume unhealthy processed food. Fourthly, permanent units for NCD prevention really help to mobilize action and resources. We've seen that in countries where permanent units have been established in the ministries of health for NCD prevention and health promotion have helped to institutions that have dedicated personnel and a strong legal framework underpinning them have helped to basically provide institutional stewardship for NCD prevention, both in terms of policies and programs, and also in terms of increased resource allocations over time. Simply put, if you have dedicated personnel driving NCD prevention whose jobs are committed to NCD prevention, then chances are that you will be able to mobilize more resources for NCD prevention. Fifth, institutions for multi-sectoral coordination are absolutely critical. NCD prevention requires interventions that go beyond the health sector in areas like education, food and agriculture, media, sports, local government, environmental regulation. So this cannot simply be health system focused approach. And countries that have had functional NCD committees, such as Jamaica, Tonga, Mongolia, Kenya, Sri Lanka, have generally done better at mobilizing resources for NCD prevention compared to countries that have not managed to establish such committees. Taxing, this has to be a key lesson and needs to be repeated over and over again. Taxing unhealthy consumption works regardless of how much the food, alcohol, and tobacco industry tell us. Across contexts, whenever the taxes are hiked on tobacco, alcohol, and sugar-sweetened beverages, they have helped bring down consumptions of those risk factors. In some countries, these have, in addition to bringing down consumption, they have also helped finance health promotion efforts and improve other health indicators. And the main issue really is in this, even though it's been demonstrated to work, the fear of increasing taxes and the fear of public opposition to taxes and inflationary pressures acts as a deterrent, in addition to obviously industry lobbying. Industry interference continues to be a major obstacle to institutionalizing NCD prevention. It is an impediment to both revenue raising. We've seen in many of these studies, we find instances of lobbying, of legal action, or of corrupt industrial practices that have overturned tax increases. We've seen even somehow some instances of even industries being complicit in the change of governments to help to bring about reduced taxes for their industries, such as took place in Sri Lanka with the change of government in 2018, where a lot of tax increases were reversed. And similarly in Pakistan, with the tobacco industry undertook underhanded practices to reduce revenue after tax increases and force the government to cut taxes again. And these are also, the industry has also been an impediment to obviously reducing the consumption of these practices. We've seen in Pakistan, legal battles have taken place to take down regulations related to trans fat elimination in Pakistan. So what we really need are both effective civil society coalitions and committed political leadership that can resist this pressure. Finally, data and surveillance gaps continue to be a massive issue across country contexts, and we really cannot fight NCD epidemics without disaggregated information available. On NCDs, civil society advocacy and regional collaboration have also been critical in countries where these coalitions are weak. So is NCD prevention. Again, as detailed earlier, NCD prevention must be anchored in primary care, and there must be like a continuum of care, whether you're talking about monitoring NCDs, whether you're talking about responding to them, whether it's early detection programs. Primary care needs to be strengthened. And the settings approach is very effective at bringing about behavioral change in workplaces, schools, towns, and villages. Finally, no progress is possible on NCD prevention without political leadership, particularly because health promotion efforts often have less visibility and political salience. And there's an incentive structure that makes politicians spend more resources on visible health infrastructure and ignores intangible goods like health promotion. So many important prevention measures often are seen as unpopular, including taxes and health promotion, and they also have powerful lobbies. So political leadership that can sort of tackle all of these issues, generate public demand, and resist industry pressure is absolutely critical. So I'll end here. These are some further areas identified for study, which you can go through. I'll share the presentation with you for the researchers who are are sharing this right now. And in conclusion, again, so NCDs are really the health crisis which underlies the devastation and that is being wreaked by the COVID-19 pandemic right now. NCD prevention is low cost. It's been demonstrated to bring about massive returns on investment just within a few years. And investing in some of these basic common sense best buys can both reduce disease burden and create economic benefits. If we can reorient our health systems to prevent NCDs right now, we can improve the health of our populations, free up resources for other human needs, and be better prepared to face future crises and pandemics such as the one we're facing right now. Thank you so much.
Thank you, Amar, for that rich overview of the 10 country case studies work. It was very interesting, and I did not want to interrupt you. A lot of hard work has gone into this, and I want to congratulate you once again. Thank you also for bringing out the common threads as well as the unique the challenges that are unique to every setting. I would now like to request Sir George Elaine for his keynote address. Sir George Elaine needs no introduction. He is one of our greatest global health leaders. And with respect to NCDs, he is the person who started, I believe he's the one who started the global NCDs movement. He is the one who took NCDs out of the World Health Assembly and took it to the UN General Assembly through his advocacy in the Caribbean. He has made a huge contribution to advancing the NCDs agenda. He's a great human being and an amazing human being, and I have the privilege of knowing him very well. So George, you have the floor now.
Thank you very much, Sanya. And I'd hope that you would say that I'm your friend.
Of course, a great friend. Thank you.
No, seriously, thank you very much for that contribution. And thank you for the invitation to speak today. And to Kasim, your son, for the arrangements he's made to make this possible. And let me thank Amar for that really tremendous tour de force. I wish to congratulate him and the research team for the excellent work. I know one of the countries fairly intimately, and I'm really impressed by the scope of the analysis throughout the documents, the relevance of the recommendations, and the clarity of the reports, and the methodology, which is so well described. The graphics are excellent, and the data presented to justify the conclusions. And in the short period of time, Amar, you really did a tremendous job in presenting the essence of the reports. The basis of the research, as I said, was the acknowledged concern for the importance of NCDs. But despite that concern, there was insufficient financing. That's why it was titled Financing of NCD Prevention. The countries of the world bought into the global plans of action that have been elaborated in the World Health Organization, and the heads of government convened thrice in the United Nations to examine the problem and to commit themselves to address it. And the issue of financing has never really been distant from our discourse on NCDs, but much of the discussion on financing has dealt with the whole spectrum of promotion, prevention, treatment, rehabilitation. And many of the recommendations proposed as a generalization have been that countries dedicate their own resources to solving the problem. I have to confess, I have a difficulty with the generalization of that proposal, because in some 30-odd countries, the very poor countries, they just don't have the money to do what is proposed in general in terms of mobilizing their domestic resources. But this research was different. It was different and was predicated on the idea that in a group of low and middle income countries, there was the possibility to address part of the problem, which was appropriately, I think, crafted rather narrowly. It was the issue of financing prevention of NCDs, and more specifically, within the context of the known risk factors of tobacco, alcohol, inadequate diet, and physical inactivity. And the reports from the countries in dealing with the specific remit also present a wealth of contextual information, as you heard from Amar. Contextual information that bears on the pertinent recommendations. And the research, I think, and I think appropriately, does not go into secondary prevention of NCDs. I won't attempt to analyze the findings. Amar has done that brilliantly. But there are similarities and differences in them, as well as in the recommendations, that I found absolutely fascinating. All countries accepted that NCDs represented a major health and development threat. All accepted the need for prevention and health promotion. But the common recommendation, the one I found that had more salience, was the need to increase funding for this aspect. Can you, there's something else on the screen. It says, make it fast. Sandy, can you hear me still?
Yes, Sir George, we can hear you.
Oh, okay. There's something else on the screen. Never mind. The common recommendation, as I said, for this was the need to increase the funding for this. There was a wide range of budget for prevention, as Amma has pointed out, from the low of 0.2 in Belarus to 6.7% or 6% in Tonga. But what for me was really striking was there was no correlation with the burden of NCDs and no correlation with the wealth of the country as measured by other economic indicators. And even though it's universally accepted that health taxes represent a viable revenue source and an approach to addressing the risk factors, I found there were considerable differences, not only in the use, but in the scale of taxes. And with one exception, there was a great aversion to hypothecated taxation. In all, there was a prioritization of a treatment over prevention and promotion as evidenced by the relative budgetary allocation. And this, for me, was but another manifestation of the universal discounting principle, which is well known to economists. Individuals and communities will opt to defer costs to the future rather than incur them now, and they prefer benefits now rather than in the future. Thus, any money that they have available, they would prefer it to be spent in conferring the benefits now rather than in an attempt to present or to prevent future costly events. But of course, given that the future will always come home to roost, money will have to be spent anyway in dealing with the problem. And as Amar pointed out, prevention is never popular politically. As I gathered, one of the main reasons for this research was that the findings should be disseminated widely so that other low and middle income countries might learn from them. I think there are some excellent examples. There are many excellent examples that might be emulated, as Amar pointed out. One that struck me was the creation of a specific health funds, health funds that might be supported by health taxes. But let me suggest that in addition to sharing best practices, I would propose that in the dissemination process, you give attention to one fundamental conundrum that this work poses. There is acceptance of the importance of NCDs. There is acceptance of the tractability of the problem. And in most cases, structures have been put in place for prevention and promotion. And yet, the budgetary allocations, which in theory are one of, if not the most important measure of the perceived gravity of the issue, these budgetary allocations are incompatible with that perception. Thus, a critical issue thrown up by the research is not only the ubiquitous nature of the problem and all the other things that Amar presented so brilliantly, but for me, the nub, the pith is what is the possible solution? What is the approach needed to convince political and other decision makers that more funding should be allocated to this area, since we assume that budget is the best measure of priority? And I would ask you not to cite lack of political will as being an impediment. I am always uncomfortable when we fall back on that old trope of we need more political will, we need more political will. As I have found, in most instances, there's no lack of political will. There may be lack of political wallet, there may be lack of political clout, but the will of most politicians is to do the right thing. And intrinsically, they believe that this is the right thing. So I hesitate often, always, about adducing lack of political will as an impediment. I think the problem perhaps lies in how the issue is communicated and the kind of data that frame it. How the issue is communicated and the kind of data that frame it. And I ask the questions, should it be framed as a public health problem predominantly? And we should believe that our mortality and morbidity data should be enough to convince policymakers? Should it be framed as an issue of human rights? Should it be framed in economic terms, in the sense that the diseases represent a tremendous current and future cost for society, and their eventual treatment will compromise the available fiscal space and displace other important public problems? Should it be framed in terms of the impact of NCDs on the quantity and quality of human capital that is needed for countries' economic health? I have a special interest in this last. I'm currently involved in a project which explores the nexus between healthy longevity, NCDs, and human capital, because I believe that the world's population is aging, and it is critical to ensure that this aging population, which still represents valuable human capital, that this aging population continues to be productive and enjoy the appropriate welfare benefits for as long as possible. So given that NCDs represent one of the major factors that militate against productive aging, it is critical that society tries to ensure that adequate preventive measures are applied throughout the life course. But as the social constructionists tell us, our perception of what we believe to be incontrovertible and impregnable evidence actually may not seem so to others. Our social constructionists tell us that success in elevating issues to the level at which they attract attention has very little to do with what we believe to be objectively credible data based on our perceived reality. Success depends on the ideas the supporters have and the manner in which they advocate for its importance and for attention to be paid. It is how the supporters frame these ideas in such a way that they compel interest, and in this case, compel budgetary allocation. And I've come to believe that it's not only the presentation of what should be considered objective evidence, but there's also the need for leadership, institutions, and champions within a wide epistemic community, the need for champions to frame and advance these ideas. And in the context of institutional leadership, I would give pride of place, of course, to civil society, because I believe that civil society is the only one of the institutions that is capable of mobilizing the voices and interests of persons who are intimately affected by NCDs. As Joanna knows, I've been a great proponent of saying that when we do ourselves ill if we only cite mortality and morbidity statistics and failed to realize that probably more than half the world's population is living with one or other of the NCDs. And in many instances, they remain silent to much of the debate and discussion that takes place in other fora. And we have the example of other areas of public health importance in which the institution of civil society was critical in mobilizing the resources needed to address the problem. We only have to consider what happened with HIV/AIDS. We only have to look at what is occurring now with neglected tropical diseases, the need or the possibility of generating the enthusiasm of public society, of civil society, in articulating and in framing the issue in a way that attracts significant political interest. But as Amar has pointed out, and Sanya said from the beginning, there's one new factor which I think should figure strongly as the ideas are developed that go into framing the issue for presentation to decision makers. As everyone knows, it is clear that NCDs represent an increase of mortality and morbidity in this COVID-19 pandemic. But one of the things I discovered, it is not only with COVID-19, but in the viral epidemics of SARS and MERS, NCDs also contributed to increased mortality. And parenthetically, This was not so in the case of the great influenza epidemic of 1918. And the answer is quite simple. At that time, the average age of death was in that pandemic was around 28. The life expectancy was in the 50s, and there was not a large population of older persons with NCDs. And I posit that COVID will not be the last viral pandemic. COVID will not be the last global viral pandemic. And if we accept that thesis, and given our knowledge of the additional risks posed by NCDs in these viral pandemics, I think it behooves us to do everything possible to prevent these disorders, or at least delay their occurrence until as late in life as possible. Hence, of course, the need for prevention. And I would submit that the possibility of elaborating an appropriate frame for the presentation of this problem to decision makers, that possibility should include mention of COVID, and it should include our knowledge of the negative impact that NCDs has on the outcome of these viral pandemics. So in conclusion, Sanya, I wish to congratulate very warmly the researchers for the quality of the work, which has become even more salient now. I wish to congratulate them on the clarity of the recommendations. And these recommendations leave no doubt about the urgency of increasing funding for prevention of NCDs. And I think, I'm sure that the value of this work will be enhanced with a very wide dissemination. I would hope that in the process of dissemination, you include discussion of the thorny issue of how to achieve that goal of increased funding. Not only state it as a desideratum, but have some discussion of how one will address this thorny issue of increased funding, and not to make the affirmation that it is necessary, but to think how it might be done. I have made some suggestions, and the central suggestion I make is that we consider how the problem should be framed to attract maximal political attention. I also point out that the frame will have more impact if the possibility of other pandemics like COVID-19 are indeed included, given, as we've said before, the increased mortality and morbidity from NCDs during COVID. I know that much of the current discussion speaks of, many leaders speak of building a better world post-COVID. And I sincerely hope that this project contributes to that post-COVID world, having increased funding for the prevention of NCDs. Thank you.
Thank you, Sir George, my dear friend, Sir George, for that stellar keynote. And thank you for reiterating the importance of the manner in which the framing of the problem is so crucial to opening up, and I quote you, the political wallet. Your point about the importance of disseminating this widely is also very well taken, and I would like to recommend to my former colleague, Dr. Sabah, that this work be actively disseminated, and I'm sure that they will reach out to you to get it, to get a separate transcript of your keynote, which I think merits to be disseminated standalone as a, as an overarching commentary on the work. Thank you, Sir George. There are several questions for you in particular, and I'm going to return to those after we've heard from the panelists. We now turn to the panelists, and I really look forward to their views on the work. We'll go first to Johanna Ralston, the CEO of World Obesity. Johanna, you have the floor.
Thank you so much, and thank you, Sanya. Thank you, Sir George, and thank you, Amar, for an excellent presentation and summary. Also, I just want to send greetings and prayers to all of you and who are close to a current COVID outbreak that's particularly frightening, and really pray for everyone's health and that this will be contained soon. I'm here in the U.S. at the moment, so first of all, building on what Sir George just said about really describing this in the context of COVID. Moving forward, I almost would perhaps take it one step further and think about future pandemic preparedness, that we really position NCDs, addressing NCDs as essential to pandemic preparedness. In the case of obesity, which is what I work in now, but as you may know, I've worked in NCDs for more than 2 decades, and I've lived with an NCD for 3 decades. But in the case of obesity, we did a report just looking at the countries with the lowest rates of COVID death and the countries with the highest rates of COVID death. And there was a 90% correlation in terms of high levels of overweight and obesity. And we can think in this case of obesity as a good, perhaps also indicator of other NCDs that it drives. So, you know, Burundi and Vietnam were the 2 lowest sort of per capita rates of COVID deaths, and US, UK, and Belgium were the highest. So that's a funny way of looking at even the one country there that was included in this list. But so clearly, multiple obesity is an indicator of multiple NCDs usually, and it's the severity that seems to contribute to the death. But the point here is that we look at NCDs, one of our challenges, and I know you mentioned it, Amar, is that they don't happen over the convenient sort of political life of an elected official, where there's that sense of urgency that this is something that you'll have to deal with within the term that you're in office, just to be very blunt, which has a different sense of urgency. It tends to happen over a longer time. But now we're looking at what's happened with diabetes, cardiovascular, cancer, obesity, where they're contributing to the severity and mortality from COVID, that in fact, you've taken something long-term and turned it into something urgent and acute, which if we think very strategically about, that's a way to say this has suddenly become an acute problem, not just a sort of long-term chronic problem. And as such, perhaps it can generate more attention and resources than it has otherwise. And I think building on, I really appreciate I appreciate everything Sir George said, but particularly this idea that it's not that political will is lacking. I sometimes think there's something about, it's not just having the will, but it's also perhaps having the ability to withstand so much pressure, as Jamaica had to do in order to institute, for example, changes in tobacco, to know that industries will leave and there may be economic consequences of some of these policies, and doing them anyway. So it's not just, it is political courage, but it's also some ability to have enough support, enough of a sort of a movement around it, which is again where civil society comes in. And so I think that those were really excellent and useful points. And then I think, because I really want to hear from my other colleagues and experts as well, I will just make another comment that, again, the Food Systems Summit, the UN Food Systems Summit, is happening in September. And I really think we ought to publish some of this and use some of this, because I think it's data that it hasn't been in the conversation yet. And that's something I'm very happy to follow up on, because we are somewhat involved in the summit. And just remembering, as you know, the civil society voice and the right narrative. We need narrative and evidence. You have evidence, and we need the narrative now to accompany that. And the patient voice can be incredibly important there. The voice of lived experience of many of us here who probably lived with NCDs, to partner along with the professional and the public voices that I think we've worked with for a long time. So thank you, and I'm looking forward to hearing from my other panelist colleagues.
Thank you very much, Johanna. I'll give the floor now to Douglas Betcher, former Director of Non-Communicable Diseases at the World Health Organization.
Yes, thank you very much, Sanya. Greetings to everyone, and I hope everyone is staying safe and sound during these difficult times. Thank you. Special thanks to Sanya for bringing us together in this virtual globalized interface, and special thanks to Amar and the research team for producing such a wonderful set of case studies. I'm super glad to be speaking with you today as part of, and being a real honor to be part of the Projects Advisory Committee along with Joanna, Sir George, and other colleagues. As my other colleagues had mentioned and emphasized, the release of these papers and our discussion today could not be more important or timely. We are, I think, at an inflection point that could mark either a global acceleration, hopefully, of progress towards the attainment of our commitments on NCD prevention and management, or alternatively, not so desirable, the years when a unique opportunity to save lives, support development, and ensure a better future was squandered. I hope we don't go in that direction. We are, on the other hand, it's important to say that we are not on track for a 1/3 reduction in premature mortality from non-communicable diseases by 2030, as agreed in the Sustainable Development Goals. In fact, today, only 17 countries are currently predicted to attain the target for women, and even less, 15 for men. As my colleagues have emphasized, the collective challenge means that 15 million premature deaths from non-communicable diseases annually. It also means a world more vulnerable to the COVID pandemic. As Dr. Tedros, Director General of WHO, concluded recently, fewer NCDs would have meant fewer deaths during this pandemic. And we shouldn't take that lightly. Due in part to a decade of insufficient action on NCDs, 1 in 5 people have faced a higher risk of severe COVID-19 because of underlying NCDs. People living with NCDs have also been left in an incredibly vulnerable position by the disruptions COVID has caused. For example, 37% of countries, of all countries reporting to WHO recently, have reported major failures in NCD health services provision as a result. In our case studies in this project, we see that nations making significant progress and considerable efforts towards meeting the varied challenges of an epidemiological shift from communicable to non-communicable diseases. We also see that these efforts have nonetheless been, until this time, insufficient. Encouraging, but insufficient. One of the reasons for this, a common thread to all the case studies, which is generalizable, I think, to most countries, is that there is an inadequate prioritization of resources towards highly effective and cost-effective preventive interventions targeting the major NCD risk factors. Obviously, the underlying vision, the underlying raison d'etre of these studies, these case studies. This is despite the conclusive evidence that interventions targeting tobacco use, unhealthy diets, physical inactivity, harmful use of alcohol can contribute up to reducing premature mortality from NCDs by up to 2/3, with another 1/3 reducible with health systems able to meet the management needs of people living with NCDs. As noted throughout the case studies, such resources as we are devoted to, that are devoted to NCDs are often allocated disproportionately to secondary, tertiary, inpatient and outpatient specialist healthcare services of conditions over choosing cost-effective preventive interventions. And this is kind of, I think we could look at this as kind of an inversion of a distribution according to a logical, evidence-based inversion of a distribution according to relative cost effectiveness. So because of the political challenges of reallocating spending away from people and expensive, debilitating, life-threatening conditions, an effective solution, I think, for rapidly accelerating progress on cost-effective NCD prevention is to grow the physical pie with health taxes rather than dispute the pie's division, so to speak. When implemented with effective design and large enough rates, health promoting taxes on tobacco, alcohol, sugary beverages directly target NCDs by increasing the prices and reducing the demand for these unhealthy products. At the same time, they are effective revenue boosters over both the short term, the medium term, that produce funds, a funding stream, which can be used to invest in and jumpstart highly cost-effective yet underutilized NCD prevention measures. In this respect, I'd invite colleagues online here to refer to the recently published WHO Technical Manual on Tobacco Taxation that is focused on advising countries how to scale up their tobacco tax policies for win-win effects in public health and revenue generation. For example, Mongolia and Tonga in our study provide best practice examples of health tax revenues used to establish a health promotion fund for combating the main modifiable NCD risk factors. Another thread, I think, that has been emphasized by Amar throughout running through these case studies, and the principal reason in many countries for the gap between the global aspirations towards NCD reduction and our reality of stalled progress is the negative commercial determinants of health. And as we've discussed, fostered by tobacco, alcohol, beverage, processed food industries. Our case studies show even nations with determined programs of action on the major NCD risk factors having their progress undermined or frustrated during moments of weakness, such as political transitions, ruptures. This is seen, for example, we've seen, for example, in how the industry actors variously exploited Sri Lanka and Mongolia's changes in government, as well as Kenya's devolution of public health powers. Similarly, otherwise determined governments are often swayed against the most effective actions, in particular health taxes, by false, exaggerated, or misleading arguments by industries that frame the cultivation, production, sale of their products as economically beneficial or even indispensable, as seen to varying extents, for example, in the case studies Tonga, Zambia, and Mongolia. So in closing, I say on this front that in order to address the other negative commercial determinants of health, we should look very carefully to the WHO Framework Convention on Tobacco Control, Article 5.3 on tobacco industry interference, and the Conference of the Parties on the Framework Convention guidelines for its implementation, which provides a template for best practice prevention of industry influence and interference applicable not only to tobacco, but also to other commodities and industries such as alcohol, sugary beverages, and processed foods. Just as the tobacco industry was a pathfinder for other harmful industries in developing tactics for expanding the depth and reach of the market for their deadly products, the WHO FCTC experience is the obvious pathfinder for countering the commercial determinants of health across all sectors and industries. And what I think is needed and is highlighted in the Amar's discussion and in the case studies is the national implementation of measures providing for intersectoral governance, protection from industry interference, which will then assist unlocking measures for reducing the supply of and demand for unhealthy commodities. So I'm really thrilled today to see the results of our project's case studies, to see the light of day, and I'm really looking forward to the dissemination and to encouraging the use for policymaking shifts and increasing the deficit of financing at country level. So over to you, and thank you, Sanya.
Thank you, Doug, for those comments. We'll go straight to the third panelist, and I'd like to give the floor to Dr. Palitha now.
Thank you so much. I'm honored to join today for this webinar. And congratulations to Amma. It was a fascinating presentation, excellent study done. I think there was a critical analysis of the ground situation of 10 countries, which enlighten us on the present progress made in these 10 countries. And let me first quote the WHO NCD Progress Monitor 2020, what highlights that despite many proven interventions and commitments to combat NCDs, progress has been slow and uneven globally. Challenges to achieving these commitments include lack of political will and priority setting, the impact of economic, commercial, and market factors, and insufficient financing and capacity in countries. I think these are the factors really highlighted by this study as well. And data from 194 countries highlights that there are only 2 indicators out of 10 indicators that half of the countries are fully meeting. So you can see the progress made so far. We are in 2021, and we have to have progress and targets reached by 2025 and 2030. The report on WHO Independent High-Level Commission on NCDs, where Dr. Sania Nista also has contributed so much, highlights that billions of people around the world are affected by NCDs. The growing trend of population aging has enormous ramifications for the prevention and management of NCDs. And this high-level commission on NCDs made 6 major recommendations. One is political leadership and responsibility from capitals to villages. Prioritize and scale up, embed and expand NCDs within health systems and universal health coverage. Collaborate and regulate. Government should increase effective regulation, appropriate engagement with the private sector, academia, civil society, and communities, building on a whole of society approach to NCDs, which was highlighted again and again by Sir George as well. Finance and finally act for accountability. So these are the factors again and again highlighted in these studies by Ahmed. Let me quote one of the study we have done when I was in Zero. The analysis we have done in Zero in 2018 among 11 member states on multi-sectoral governance shows that all countries in the region have adopted a multi-sectoral action plan to address the NCDs. In keeping with the plans, most countries have established a national NCD governance body for multi-sectoral coordination. I think that's a very important thing to be understand. Prime ministers and health ministers share the governance bodies in 9 out of 11 member states, demonstrating the region's increasing recognition of the importance of political leadership in NCD governance. So ladies and gentlemen, if the countries which want to commit, we need to get the highest level political commitment and substantial financial allocation to make a progress. So having said that, let me focus on few areas. I think much have been said by Douglas and Sir George, but let me say one of the area that I would like to highlight again and again is the importance of multi-sectoral governance and highest level political commitment. What are the governance mechanisms different countries have? It's not very strong. As our study has highlighted, the countries where Prime Minister is chairing and 2 countries where there was one country, President was chairing the multi-sectoral governance body, and 1 country it was the Vice President, where actions are be taken. All the ministries which need to be on board are coming on board. And the cases where ministers and the high level officials are sharing, you don't see that much of commitment. So this multi-sectoral governance mechanism and the highest level political commitment is one of the very important area. This study also doesn't show much on the integration of NCD services to primary health care. As you see now, we are focusing so much on universal health coverage, and PSC is the way forward. And I would like to highlight the Pakistan case where recently came out with USC benefit package with 88 intervention, costed intervention using DCP3 tool. And that intervention, there were a lot of NCD interventions as well. You can have NCD screenings and then of course treatment, care, all that at the level of primary health care. So primary health care has to be a comprehensive health care, patient-centered health care, and quality health care. So therefore, the NCD services has to be integrated. There are a lot of studies we have done in different countries. Bhutan is one country where they have come out with NCD essential drug list, and all the primary healthcare facilities, these drugs are available. And Sri Lanka is another example where there was evaluation done by World Health Organization in 2015, where 98% of the essential drug list for NCD treatment are available in all the primary healthcare facilities. It's not that much of cost. And also some countries have come out with essential test list as well. And then mental health has to be integrated into primary healthcare services. So this is another area I would like to highlight for the attention. And then thirdly, the interventions on diet, salt and sugar reduction are very much less. And there are a few examples we have quoted. Sri Lanka is one country where traffic light system has been introduced to reduce the sugar consumption. There was 1 or 2 other countries in this case studies also highlighted that, but progress is not that much. there are a lot of Latin American countries which have who have started implementation of traffic light system and food labeling system. That may be another area where we need to focus. Tobacco and alcohol, I think Douglas has elaborated so much on alcohol taxation, and I think WHO Best Buys is proven interventions for NCDs. There are best practices from different countries which we can learn, and even these case studies from 10 countries have highlighted all this. Integration of NCDs to primary healthcare to deliver quality, comprehensive, and patient-centered care with population-wide interventions may be the way forward as we see. And highest level political commitment with financial allocation is extremely important. And finally, I would like to again highlight the multi-sectoral policies and governance with a strong accountability framework in place is extremely important to move progress. So I stop with this. I'm very much optimistic that these case studies will useful for these countries, not only the 10 countries under study, but also for other countries to use for decision making. I'll stop here. Thank you so much.
Thank you very much, Dr. Palitha. In terms of housekeeping, I'd just like to announce that this webinar is going to run till 11:15 Pakistan time. And we'll now move to the last panelist. Madiha, you have the floor now.
Thank you, Dr. Nishtar. Thank you for your leadership on this. Excellent presentation, Amar. And thank you to all the panelists and Sir Elaine. I just wanted to highlight a few things and respond to some of the issues that everyone has raised. So the first is the presentation is fantastic, and particularly for us here at IDRC, it provides a holistic view. We worked on the individual risk factors quite a bit over the past decades on tobacco, alcohol control, SSB, to a certain extent, a lot of the work that Dr. Palitha was referencing on food labeling, etc., which didn't come up because here we were focusing more on financing. But it's good to take a step back to look at that 10 countries in one go, because you see patterns that emerge. And this goes back to Sir Elaine's specific point, because it's knowing what those patterns look like helps channel where change needs to come from. And one thing I wanted to highlight that increasingly is going to be an issue, seeing this in the climate change conversation as well, it's going to come up in food conversations, is that these issues don't stop at borders. So air pollution is one of those where we're looking at over 4 million deaths a year. The impact of this falls on poorer countries or communities that are living more at risk of environmental degradation. And yet the production or consumption of fossil fuels is somewhere else. So what does that mean for financing and justice? And I'll come back to that in the second point, which almost everyone referenced to, this disconnect between importance and attention, and disconnect between, again, attention and something as spending and the effectiveness of NCD prevention. So Amar, you mentioned the statistics on this, but it is very clear this is a very cost-effective approach, and yet because of that disconnect, we don't talk about that. It's a challenge. And Vietnam, I thought, particularly in your list of countries, is an excellent example of this. Again, we are supporting researchers working on tobacco control initiatives. And yet Vietnam is one of those countries in this pandemic that has had an excellent pandemic response. I mean, they followed a zero COVID elimination strategy and has protected their population really well. So there is definitely that level of political disconnect, importance of spending and attention and then results. And we see that disparity in the way infectious disease versus NCD is treated, even in a country like Vietnam. And here I would like to, Sir Elaine made a very, very important point about measuring importance by budget allocation, but there is a secondary point that, and again, Amar, you raise this in terms of civil society participation and mobilization being important. Johanna, you also raised it in terms of, the life cycle of a politician will be slightly different from, again, civil society movements and larger social movements. But I also want to raise in this as a possible opportunity is a changing acceptance or the changing consensus around macroeconomic policy and option tools. And here we've had globally a consensus upon, certainly that there's a set amount of money available, and there's a jockeying for what is possible to spend, and because of that artificially constrained envelope, NCDs often fall to the bottom of the pile, despite, again, with the return that we get on NCD prevention investment. But that is hopefully changing, and this might be one of those galvanizing efforts that we can use, that there is not necessarily an artificially constraint on what you spend and where you spend, and that could be one of the ways that we mobilize around advocating for higher spending on this. Amar, as you said, it's not an either or, and I think making that case more strongly is very, very important. And then finally, I would like, and hopefully those here can reach out, because this piece of work is fantastic, but for us, the most important is what next and how do we take it forward. What excited us most about this work across 10 countries is this potential for collaboration and peer support, and to a certain extent, seeing the way the advisors have commented on this. I know Dr. Nishtar really leaned heavily on her network to have access to information that otherwise is not available. And again, strongly endorse Amar's main contention that research can be a means of transformation. So in an ideal world, I know pre-pandemic, our plans were very different. To highlight this work, when it was in draft form and it was formal, we would have taken it to WHO convenings, whether on the financing of NCD conversations or generally NCD Commission conversations, or other places, other global health forum conversations. But of course, this past year, whatever attention there was has also been sucked up into the pandemic. And Johanna, thank you for raising this. The Food Summit conversation, which we're also very heavily engaged in, is coming up this year, and this is directly relevant. So let's not lose sight of these opportunities. And secondly, this collaboration and change, the coalitions for change, I think, are really important. So people that you've worked with, other members of the research team that have contributed to this, it would be really good to keep this as a conversation piece, even if that attention, even if the space or the oxygen, to use this, let's not, I think that's a horrible analogy, even if there's not a lot of immediate attention to this. And I think one of those things, Yasser brought it up in one of in the questions that he raised, it's not just that higher incidence of NCDs poses a higher COVID risk or the severity of disease. There's a secondary impact. Those surviving COVID now living with chronic conditions. So this is going to, the global pandemic is going to create a higher caseload. And so this will remain incredibly important. And then finally, I think what the whole, the 10 case study set highlights make it very important is this cross-border conversation is very, very, very important. So it comes up in Food Summit. I brought up air pollution precisely for that reason, and other factors. I think for change to happen, we do need to galvanize conversations across borders. Researchers find it slightly easier. I think, if nothing else, the past year and the pandemic has shown that research collaborations have exploded internationally. And let's take that further in terms of social movements as well as I think global policy conversations. Some of the things that we have learned that have been positive, as a part of necessity, can be used for change. And then finally, Douglas, just your overall point on really directly addressing the commercial determinants of health, I think remain very important and something that we need to take very seriously. Thank you. Excellent work.
Thank you, Madhya, for your comments. given the time constraints, we have probably for just one question, and I was sifting through the long list. The role of behavioral design and non-tax regulation. Doug, do you want to take us? Doug, would you like to comment on the role of behavioral design and non-tax regulation?
Well, I think the heart of the Framework Convention again is entitled non-price measures. So I discussed a lot of the price measures, but looking at a combination of comprehensive strategies like smoke-free policies, effective plain packaging, graphic warning labels, primary healthcare, education, counter marketing, in concert with price measures. And we've seen that those interventions taken as a comprehensive package are slowly but deliberately in countries that have implemented at the highest level being effective instruments for changing behavior. And we looking back on and probably Johanna will want to comment more, but likewise we can see parallels for similar types of non-price measures for reducing childhood obesity or alcohol consumption, etc. So I think that a lot is to be learned from the experiences from the Framework Convention, but already we've learned a lot in addressing the other modifiable risk factors that we've been discussing today and are addressed in the case studies. Over.
Johanna, do you want, perhaps you can just come in on this point, and in addition to this, another as well, because there's another very interesting question about the role of preventative communication and lessons from COVID with respect to how they can be applied to NCDs. Johanna.
Sure, thank you. Yes, I think building on what Doug said, absolutely. So if you look at the Ending Childhood Obesity strategy, commission strategy, which of course Sanya chaired that commission, it's very, very much not about, it's about schools, it's about prenatal care, it's about various pillars that are certainly other than price. But in terms of lessons learned, maybe I'll just make a couple, maybe an observation that I actually do think, as Douglas said, we're in a inflection point here where we can finally, we've actually gotten, I think, more recognition and attention for NCDs, and certainly from where I sit for obesity, and as being, in fact, driving so much of the morbidity and mortality, and therefore the cost, that has a, there is a political door that we're knocking on that's quite open, I would say there. But so we can, but in terms of collective mobilization, I think what is it about the countries that did well, that had lower rates? Certainly it's easier if you're a contained island country, there's no question about that. You can control your borders. But there was also something, and in some ways authoritarian countries did well, but there's also something I'd like to just maybe going back to that point that I think Sir George raised about the lived experience. There's so many people with lived experience of NCDs, and yet we still struggle to get attention. One thing I wondered about in terms of many of the Asian countries that had the lived experience of SARS, prior SARS, that there was this rapidity with which they responded and adhered to government and public health measures around this, that just hasn't really been, that wasn't the case in countries that didn't have such a painful recent memory of what it actually means to have a pandemic like a SARS-related pandemic. So there's something there that I think we can certainly learn from, and obviously the collaboration that it took to do the extraordinary work to come up with vaccines in 9 months that often take, there's many diseases for which we have no vaccine yet, and yet 9 months we have, many viable vaccines. It's incredible. So those are just some quick observations that I hope are useful. And I just again want to thank the other participants for really thought-provoking and I think quite exciting comments. And I really hope we can think of this as an inflection point. Thanks.
So thank you very much for what has been a extremely stimulating discussion. I now have the unpleasant job of bringing this webinar to a close, and I'm not going to summarize what has been a very rich and stimulating discussion. With respect to this work, I only want to say that the work has not concluded, it has just begun. Because the compendium of case studies can be a very important advocacy tool for policy and to mobilize, in Sir George's words, the political wallet that is necessary to fund NCD prevention. So with reference to the dissemination, Heartfile clearly has a charge for the way forward. They really have to invest in dissemination appropriately through all the different avenues. And it's really going to help because all of these 10 country case studies have already been accepted for a publication in a peer-reviewed journal that is PubMed indexed. So we really look forward to the next steps. And I want to congratulate Amar once again for a stellar job done. I want to congratulate Heartfile for keeping up with the tradition and for coming up with yet another quality analysis. And with respect to today's event, I want to thank Sir George, Douglas, Johanna, Dr. Pradlita, and Madiha for a very stimulating discussion. Sir George, Douglas, Johanna, Ralston, I think our Rachel Nugent, Robert Beaglehole, many of our friends who are not with us at this dissemination event were very closely involved when the study was being designed, particularly when the methodology of the 10 country case studies was being conceptualized. And I want to take this opportunity to thank them also. I also want to thank our co-investigators, Yasir Bhatti, who was unable to join us for the dissemination event, and Ali Islam Gauri, who took the lead role in writing up the Iran country case study. Surely there will be other dissemination events, and I look forward to them, to the co-investigators taking a more active and a leading role. But I want to acknowledge them for the work that they did. Finally, I want to congratulate Sabha and her colleagues for a great job done. It's always lovely for me to come back to a Heartfile event. This is an organization I've been so closely involved in founding and running for many years. And it's great to see now Heartfile not requiring me in any form or shape. That is ultimately the success of institutions. And I'm very proud of the work that they've done and the way they're taking it forward. So this is not a goodbye for now. We hope to connect back with you with respect to many different aspects of this work and many other NCD streams that I know the organization will continue to spearhead here in Pakistan. Thank you. It's been a wonderful journey together. And I hope that this will be the beginning of yet another many streams of work. Thank you very much. This webinar is adjourned.
Thank you. Stay safe.
Thank you. Thank you. Thanks, everybody. Stay well.
Thank you,
Stay
everyone.
well.
Thanks.
Bye-bye.